Hey folks, my name is Beth Wright and I am one of the nursing faculty at Virginia Highlands, and I'm providing you a podcast on safe medication use for the geriatric patients. And on the on the left hand side of the screen, you're going to see your objectives for the unit. And for this one, we're talking about age-related physiological changes that take place that can lead to problems with medications. And of course, we all know aging starts, it's a natural process and begins at birth. And we start seeing changes at, around 19 years of age. And of course, it talks about being till 64 years of age, but we know we have people living longer and we're seeing changes that occur in those individuals. And, we have the cellular changes that happen and extracellular changes that happen. Basically, everything starts to decrease for the most part. And, we have that cellular aging and tissue deficits that, can diminish the body's ability to maintain that homeostasis and prevent organ systems from functioning at full efficiency there. Cells become less able to replace themselves and they accumulate a pigment known as lipofuscin. And, we have a breakdown of the elastin and collagen, and that causes the connective tissue to become stiffer and less elastic. And so, it goes on and on and on. With each body system, we start seeing changes. And in your MedSurg textbook on page 186, goes through the systems there to, showing, describing what kind of changes can happen. And it's an excellent table to look at, so be sure to take a look at that because it tells about those and it can give you an idea, okay, of what we need to assess with the patient. Everywhere from, cardiovascular system, respiratory, every system is listed there. And it also gives you pointers as far as how we can promote health for our geriatric patients in the care of each of those systems. We have other issues that happen besides physiological changes, and that is chronic conditions. Of course, that is physiological changes, but we know that a lot of our geriatric patients have a lot of medical comorbidities or medical conditions that can complicate the whole medication issue. And we know because of those chronic conditions, they may have a polypharmacy going on, meaning lots of medicines. And we also know that, the economics of all of this can cause an issue. Can the patient afford the medicines? That's, a key issue that we need to talk with the patient about. But, I've decided as I'm growing older that, getting older is not for wimps because, you feel lots of different sensations, pain, and you hear different sensations as you grow older. And I've decided that it is definitely not for wimps. So I have a few little things for you here. Seven dwarfs of old age. So we have the nappy, the wrinkly, the squinty, the rocky, the saggy, the farty, and the leaky. So yeah, some of these things are, what you're going to see with your geriatric patients. And oh, isn't it something to look forward to? I thought this was cute. If my body was a car, I'd trade it in for a newer model because every time I cough and sneeze, my radiator leaks and my exhaust backfires. So yeah, there's some things again to look forward to. Also, gave Bridget to post a cute little thing about senior texting codes that are real cute to take a look at. So hey, we gotta have some humor in here, right? Okay, so let's talk about pharmacodynamics with our older adult population. And it, involves um, drug actions on target cells and alterations in cellular reaction and functions. And we have, another issue with medication, uh, you know, going through that whole pharmacokinetics. We have issues with the reduced number of receptor sites and a decreased number of receptors, or specific systems in the body slows down. So that makes it a unique problem for our geriatric population, and it makes them prone to an increase in drug reactions. So when we think about our pharmacokinetics with our adult patients, our older adults, we have to think about absorption there. It's slowed absorption. We have a decrease in the GI tract, just about everything. Um, you may have, though, an increase in acidity, depending on the patient. And, if we have a decrease in our blood flow and circulation and gastric emptying, then we're going to have a potential delay in absorption. So if we're absorbing things slower, what's going to happen to that therapeutic level? And what will need to be done if it's slower? It may need possibly an increased dose. So depending on, what's going on with your patient there. Um, with our distribution, we have a slow cardiac output, an increase in body fat, decrease in body mass and body fluid, and a decrease in albumin, our protein. So when we think about that, we got to think about drugs that are protein bounding, may have an issue getting around to the target sites. And so, if that is the case, if the albumin level is low, then this could certainly cause a toxicity issue, because, the drug's not piggybacked onto the albumin, and it's just freely kind of floating out there in the bloodstream. So we may have an issue with that. We got to think about that. Also, you got to think about fat and lipid soluble drugs. If we have, a increase in that, then the fat soluble drugs will stay longer in the body, if we have an increase in that body fat. Water soluble meds with a decrease in our body water, that may cause less to be absorbed and less to be distributed, leaving more drug available to cause toxicity. So we need to consider these two things a part of your pharmacokinetics. Also, metabolism as our next stage of the pharmacokinetics. Of course, we have the liver that decreases in size and mass, and our circulation and metabolic rate and enzymes, all of that decreases. So if that is the case, we got to think about, again, the meds that metabolize there. The meds that have a longer half-life, they're going to stay in the body longer when our liver's not, functioning like it is at the adult stage. So we definitely got to consider the half-lives of medications. We also got to look at those liver function tests, because that's a big part of the metabolism of medications. So your ALP, your alkaline phosphatase, your ALT, the alanine transaminase, and your AST, the aspartate aminotransferase. We've got to look at those for your patients, your liver studies, and also other indications of liver issues such as jaundice or ascites. We've got to consider those. Now, excretion, primarily we think about our kidneys being the main place of where meds are excreted once they're metabolized. Although that it does happen in the GI tract as well for certain drugs, but for the most part, the renal is what we're looking at here. So, again, this is something that's affected with your older adult. They have, decreased renal function, so we got to monitor those renal labs, such as your glomerulus filtrate rate, your BUN, your creatinine. And so, if the GFR is low, the glomerulus filtrate rate, then that means the filtration system is not working well, leaving more drug in the system, in the body. And, your BUN, if it's elevated, that means the kidney function is not good. And again, leaving more drug in the body and possibly causing toxicity. So the pharmacokinetics in an older adult is very, very important to look at. Okay, so in your pharm book, you've been through the Pharm 1, and that you covered a part on your geriatric patient there. So go back and look at page 79 there, and it goes through the nursing process. We got to think about that nursing process with our medications, and our objectives list measures to promote safe drug use in older adults and assess medication usage in the older adults for indications, potential adverse effects, and safety concerns. So, thinking about that nursing process, we got to look at the assessment. Does the patient have knowledge of what their medications are for? What's their actions and adverse effects, and do they know the dosage and how to administer it, and what's the goal of therapy, the guidelines for administration? Do they, for instance, have to take it with a meal or without? Do they have to check their pulse or learn to check their pulse? What's those drug-drug interactions or drug-diet interactions where it's applicable, or drug-herb interactions? And we certainly have to assess the patient's physiological status with respect to the pharmacokinetics, such as the renal and the liver function, the cardiovascular, any kind of physiological changes that can happen. Also, if they're taking the medicines by mouth, what's their ability to swallow? What's the body mass, situation with respect to like their albumin? What's their ability to adhere to the medications? Do they, cognitively have the ability to follow their medication regimen? I know my husband's grandmother, she would write everything down, so she would not mess her medicines up. She had notebooks upon notebooks where she would every day write her medicine down after she took it, so she could not double dose there. So is there the ability to care for self, or do they have caregivers that are involved? And if so, those folks need to be involved in the plan. The nursing diagnosis, effective therapeutic regimen, risk for falls, especially with certain medications. Is there ineffective health maintenance because of not being able to take care of themselves or able to afford the medicine? And is there a readiness to learn about that? So those are different nursing diagnoses that you can use. The planning is that the patient's going to take the medicine as prescribed, and that they'll be able to tolerate based on their renal, liver, cardiovascular function. They're going to report any kind of adverse effect, such as, falls or anything for that matter, and that they'll understand how to administer the medicine, the actions, uses, adverse effects, and therapeutic effects as well, and how to adhere to the medication. Our nursing interventions are going to be assess renal, assess liver, cardiovascular changes in the body mass, assess the patient's response and their ability to maintain and adhere to the medications. We're going to instruct and teach about those adverse effects. We're going to assess those adverse effects. We're going to teach about, how to administer, what the medication's for, what to watch for adverse effects, what to watch for with, the therapeutic effects as well. And then, of course, our final part is going to be the evaluation. And again, what's the patient's response? What's the, is it therapeutic response? Is their understanding of how to give the teaching, all of that, was it productive and the patient understands all of that? And is there adherence to the medication plan, and is there a therapeutic response as well as adverse response? And that concludes your podcast.